Hello everybody. Today I'm going to be talking to you about all things pharmacy inpatient related. We're going to go over some things that are a little bit boring and some things that I'll kind of expand on a little bit. But long story short, the first couple of slides are pretty basic information, so I'll get started. I will give one disclaimer. I talk really quickly, so bear with me. And the good news is it makes it go by a little bit faster. So for the first slide, like I said, super basic information. Who are we, where are we, and how do you find us if you need us? So the main pharmacy is located on the main campus, ground floor. You're going to take the M elevators. We are actually right beside the morgue. That sounds a little bit creepier than it is in reality, and the good news is it's always cool in our space. You'll notice that the phone number is listed up here. We are open 24/7, 365. Pharmacy director is Alan Broom. My name is Katie Duffy, and I'm actually the chief clinical pharmacist, which means I oversee all of the clinical pharmacists that work on this campus. And these are the individuals that oftentimes you'll see rounding out and about with all the physician groups. They all have actually specialty areas that they focus in. So for instance, we have a palm critical care pharmacist, we have an infectious diseases pharmacist, we have IM, we have cardiology. They kind of cover the whole gamut. So in addition to rounding with these specialty service lines, they also offer certain clinical services house-wide. The other disclaimer I would like to speak about now also is that when I talk about some of these clinical services and policies that we have, these apply only to the adult patient. So we have policies that cover us for certain things like vancomycin dosing, aminoglycoside dosing, where we don't have to have a consult to actually dose these items. So for instance, if we get an order for an adult patient for Vanco, our pharmacists are going to pick the dose, they're going to pick the interval, we're going to check levels. We would order any labs like a serum creatinine if we needed it to dose it appropriately. And I only point this out because on the pediatric side, this is a consult-driven service, so I just want to make sure that that is clear. We do have an anticoagulation service as well. It is consult driven. So for instance, if you have a patient that needs to be started on Coumadin and the physician wants pharmacy to monitor it, they would have to place a consult for pharmacy to follow. And then when it comes to TPNs, again, on the adult side only, we have a mandatory order set that is an EPIC that has to be completed. Adult patients have to meet certain criteria and indications in order to be started on a TPN. And we actually have a nutrition support specialist who looks through these to make sure that patients do meet these criteria prior to starting this process. So one other important thing to note is that when it comes to anticoagulation consults and TPN consults, we do have a cutoff of 2 p.m. on the adult side. Couple of reasons for this. When it comes to warfarin consults, as you all are probably aware, this is a little bit more complicated, right, than a vancomycin consult. So we want to make sure that our specialists have time to evaluate not only has the patient been on Coumadin before, have they ever been super therapeutic, do they need to be bridged with something like Lovenox. We want to make sure that everything can be checked prior to placing that patient on Coumadin or argatroban, which is the other thing that we are often consulted for. Per policy, though, if a physician wants pharmacy to dose Coumadin and it happens to be 5 o'clock in the afternoon, the ask is that that provider would order the dose of Coumadin for that day if one is desired, and we will pick up the consult the following morning. The other thing to note is that once we are following the patient, we will follow them every single day of the year, including holidays and weekends, until the drug is discontinued or the patient is discharged. When it comes to TPNs, again, cutoff of 2. This is because on the adult side, our nutrition support specialists are the ones determining all of the ingredients that go into these. We may have to order labs. We may have to wait for those to come back, obviously, to know what to put in it. And so it's a little bit more complicated, again, than some of the other processes. In addition, if it's something outside of Clinomix and we actually have to have it compounded, this is done by an outside location. So we need to make sure that we have plenty of time to get those orders to that compounding facility so that they can get the TPN back to us so that we can then deliver it to the nursing floor for administration. Per hospital policy for TPNs on the adult side, these are to be hung on day shift because they do require a dual nurse verification. So again, just something to keep in mind. And plus a TPN in an adult patient is not really an emergency, so it doesn't have to be done right then. So the 2 p.m. cutoff is important. We want to do it correctly, not quickly. Okay, so for our satellite pharmacies, for any of you out there that may not be on the main campus, where all do we have pharmacies and what are their hours? You're going to notice every place is listed up here. Any of these locations that close for any reason at any point, know that the phone calls or any issues that arise in these areas would be directed to the main pharmacy for us to take care of. But you also can know that during any of these hours, at minimum, there is at least one pharmacist present, and oftentimes there's also clinical support available. So this is just a list of everywhere we provide services. All right, so for my first soapbox, we're going to talk a little bit about medication order verification. So oftentimes when we think about this, we really think about the provider's piece of ordering the medication and the pharmacy's piece of placing it on the profile and making sure everything's okay. In order to really kind of bring up where some of the issues arise, I kind of like to take it back to when we actually were a paper-driven system. Epic is wonderful, right? It eliminates a lot of the issues and inconsistencies we saw when things were handwritten and we could not maybe read, the order as it was written because it kind of looks like hieroglyphics sometimes, right? So, but the good thing is that back then, the order was handwritten by the provider, it was sent to the pharmacy, and the pharmacist was responsible for transcribing that order onto your patient's profile. So if the doctor, for instance, were to order hydroxyzine, that order comes to the pharmacy. The pharmacist may type in HYD. In the old system and in Epic, things are listed in alphabetical order, right? So I type in HYD as the pharmacist, and I get 5 phone calls while I'm trying to process that order. So obviously I'm a little bit distracted. I hit enter and I pick hydralazine on accident because it's before hydroxyzine in my alphabetical list, right? So I place that on your patient's MAR. You go to the MAR and you're like, why on earth did this pharmacist put hydralazine on my patient's profile? Clearly, the provider's order said hydroxyzine, okay? So then you would call me and you would ask me to fix it. The problem is that in Epic, who is picking the wrong thing alphabetically? Because it's not pharmacy anymore, right? It's the provider. So when that order comes to pharmacy, I may not know that your patient has been, let's say, hypotensive for the last 18 hours, and on no planet would it make sense for them to be on hydralazine right now, right? Remember, we're sitting down by the morgue. You're the one that knows that it's not an appropriate order. So I bring this up only to really, really stress that when you are going into the MAR and you're verifying an order, please do not trust that just because the provider ordered it or just because pharmacy placed it on the profile, that means it's correct. Okay? The pharmacist's role is really to kind of look at, are there any drug-drug interactions? Does the patient have any allergies that I need to be worried about? If it's a weight-based medication, is there a weight? Is the dose appropriate? Those types of things. If it's a PRN medication, is there an indication listed? But I'm not necessarily going to know whether or not it makes sense for your patient to be on that medication. So before you put your initials beside it on the MAR, please make sure that it makes sense for your patient. And if it doesn't, contact the provider and ask, okay? Always trust your gut. When it comes to what I just said, even with all of that, we're still going to make medication errors. And I don't say this to be Debbie Downer. It just is the reality that we live in. We're unfortunately or fortunately humans, and so we're set up to not always be able to do the exact right thing all the time, right? So we've talked about verifying orders, but other ways to prevent med errors. If you work in an area where you can scan the patient and scan the drug, always do so, okay? This system is set up to help us and to try to keep us from hurting people, right? But when you're thinking about scanning the patient and the drug, there is a right way to do this and a wrong way to do this. There is an order in which you should do this. So I'm going to give you an example. And sorry, please forgive me. I obviously have a cough. So when you're scanning a medication, let's hypothetically say you work in neurotrauma and you have a patient in bed 3 that is on a norepi drip and an insulin drip, and you happen to have both of those drips sitting on the bedside table. Number one, don't have meds sitting out on the bedside table, right, unless we're about to administer them, and try to do them one at a time. But I know it happens, so they're there. So in your mind, you've got your patient, neurotrauma bed 3 is pulled up on your MAR, and you reach down and grab what you think is the insulin drip, right? But you don't look at it, you just pick it up. Well, you pick up the norepi. Well, when you go to scan that medication, when all it is the patient that you have pulled up, it's not going to know that that's not the insulin that you have in your head. It's just going to know norepi is on my patient's MAR, so we're good to go, right? So then you, still in your brain, think it's insulin. Epic didn't tell you that it was wrong. And then you go to hang it on the pump and program it as an insulin drip, right? Oops. Because the pump also isn't going to notify you that it's not insulin because it doesn't know. So the right way to follow the process is you pull up your patient's MAR, you highlight the drug that you're about to scan. Then you pick the drug up and scan it and scan the patient. Because then if you have insulin highlighted and you scan norepi, you're going to receive an error message, right? So then that would be your clue, oops, I picked up the wrong thing. And just of note, this has happened, okay? And that's a big deal. Those are two really, really dangerous medications. So please make sure you're following the process as it's intended or it won't work, right? In addition to this, you're going to find that high-risk meds, which include heparins, TPNs, insulin, these are all medications that require a dual nurse sign-off. All right, so that means you got to have a buddy go with you to give these medications. But when we're dual nurse signing off of these things, don't just make sure that it's the right drug. You also have to make sure that it's the right dose, right? Is it the right patient? If it's a TPN, are all the ingredients correct based on what the bag says? If it's an insulin drip or a heparin drip, am I putting the rate in correctly? Again, we hear a lot of feedback that you don't have time or there's nobody to help. But I promise you that if this prevents one patient from being harmed, and as we know, one wrong dose of insulin could kill somebody, right? So if it helps one patient, it doesn't matter if it's a couple of extra steps, a couple of extra minutes. It's worth it every single time. The other thing that I want to point out here is because this is a patient safety issue and you know better. If you're caught doing this, you can be terminated for not following hospital policy. So please be cognizant. We should do it because it's the right thing for the patient. But also know that it is something that can really get you in trouble, okay? And I know that y'all have all heard about eSafe a million times today. You're going to hear about it several more times from me. This is a place really and truly where you can report anything. Anything that you could think of that needs to be reported to somebody, but you're not sure who it needs to go to, this is the place to use, okay? So when it comes to errors and near misses, a lot of times we don't think about the near misses. What is a near miss? A near miss is, I almost gave heparin to the wrong patient. Maybe, like I said, you work in neurotrauma and you've got bed 3 and bed 4 and they're both on heparin drips, right? You pick up the drip for bed 4, but walk into bed 3's room because somebody distracts you as you're walking in there, right? But because you scanned appropriately, you caught yourself and it knows that it's not that patient, right? So near misses need to be evaluated in the system as well so that we can see, well, how did this process almost not work the way that it was intended? Where could we put improvements? It is a non-punitive system and it is strictly for process improvement, okay? The only other thing I will say about eSafe, you absolutely can enter anything anonymously. I personally, as somebody that has to review every single med order that's entered into the system, would highly encourage you to put your name. Not because we're going to tell Sally that Susie turned them in on eSafe, right? That's not the point. It's so that, think about editing your own paper, right? When you're reading your own paper for school, you know what you're trying to say. So you're not going to catch the little things that are off or the little things that don't make sense because in your brain, you know what you're trying to communicate. eSafe is very similar. I open up cases all the time and I read through it and it's like I realize that there's a med error, but I cannot for the life of me figure out exactly what happened to even begin to investigate it. Or nobody's listed as being involved, or I don't know where the area is. There are all types of questions that come up sometimes when we're looking at these. If I don't know who entered it, I can't reach out to get more information. So again, don't not put something in because you don't want anybody to know who you are. If you feel like you need to do it anonymously, go for it. But please also know that really your name is there so that we can reach out for help if needed. Okay? So a little bit about communication. I don't know how many of you have worked in the Epic system. This was something that was new for us, and it's been really great as far as a tool. So RX Message is something that's available for nursing and pharmacy, and basically what it allows you to do is send communication to the pharmacy via your MAR. So there's an RX functionality on your MAR where you can pull up a medication, and let's say it's something that you know we compound in pharmacy. Well, the neat thing about Epic is you can also tell if pharmacies verified an order that a provider's placed and how long ago we verified the order to help you kind of gauge, well, should I have this? Why is this not here yet? Those types of things. Well, let's say it's a medication that we've compounded and it's been an hour and a half since we verified the order. And you're thinking, why do I not have this yet? You can send me a quick message this way and say, hey, I'm waiting on, let's use daptomycin. I haven't gotten it yet. Just wanted to check on it. The cool thing about RX Message is that I can then respond to you in kind and I don't have to pick up a phone. You don't have to pick up a phone, right? And I can say, well, I just sent Sally to the floor with that daptomycin, or we delivered the daptomycin an hour ago. Have you checked your refrigerator? All right. So it's a really, really good tool to keep all of us off the phone, which I know that nobody has time for. But I do want to point out, this is not something to use if it's an emergency. And when I say emergency, I mean a medication that your patient could be harmed if you don't get it like now. This isn't for epinephrine, right? This is for something that you need it, but if you don't get it in the next 45 minutes, it's not the end of the world, okay? Anytime it's a true emergency, please pick up the phone and call us. All right, so this brings me to turnaround time. Common misperceptions about how quickly we can have drugs in your fingers, okay? So for a stat medication, we have 30 minutes to get that to you. I know that everybody may sit there and think, oh my goodness, my patient's gonna die if I have to wait 30 minutes for an epi-drip, right? Where are all stat medications located? They're in your crash cart and they're in your medication cabinet, right, which is Omnicell at Erlanger. So when I'm talking about epinephrine for a code, you have that. What I'm talking about here is something that we have to provide to you because it is not something that we keep in the cabinet. For instance, double concentrated pressors are not something that we can always stock in the cabinets due to stability and expiration dating, all right? So my point is that if you know that it's something that when your patient's drip runs out, you're going to have this to hang before you even take the other one down. Please don't wait till the drip's dry to notify the pharmacy that you need another drip, right? Because then something that's urgent becomes emergent. So if your patient's going through that double concentrated norepi drip every hour and a half, give me some lead time to prepare that. I always ask at this point, has anybody ever actually seen a pharmacy IV room? Sometimes people have, sometimes people haven't. I only ask this because I don't think a lot of times it's understood the precautions and the standards that we have to meet in order to meet not just the credentialing bodies, but we also have to pass the Board of Pharmacies inspections. And when it comes to IV rooms are cleaner than the ORs, all right? They do air quality. There are all kinds of things that we have to do. So any of the staff that works in that area, they have to wash, gown, booty, glove, mask, hat, the whole 9 yards. There's a line of demarcation that they're not allowed to cross. We cannot even keep the printer that prints the labels for the medications in the space where they are garbing up because it will mess up the air quality in the room where they compound the drugs, which is separated. All right. And then that also doesn't take into account that the compounding hoods that they have to work under, this is not an easy process. So again, when it comes to something that we have to make, it takes more than 5 minutes. All right. So just keep that in mind so that if you need something, you know that you're going to have to give us a heads up. We try to keep people in these areas all the time, but there are times when they have to leave the space to do things like go to the bathroom, right? So in those moments, if we get a label for something that's stat, then somebody would have to dress out and go make it. All right? So 2 more slides. The first one's about ADRs. This is just to remind everybody what an ADR is and why we care. So an ADR is an adverse drug reaction. You may have also heard ADE, adverse drug event. So the point of these is that anytime these occur, we actually as pharmacists have to report these to the FDA and to the drug company to make sure that there's not anything going on with a lot, like maybe there's been a recall. What exactly is the problem? And they keep up with all this stuff and it goes into their safety data, okay? So there are a couple of ways that you can make us aware of these. Anytime you pull a medication on override out of the cabinet, it's going to ask you, is this for an ADR, ADE, or an allergic reaction? If you answer yes, we actually have a pharmacist individual or a pharmacy individual that is responsible for keeping up with these, investigating these, and reporting these. So as soon as you say yes to the cabinet, if it's true, we get a notification, okay? If it's not this way, maybe you're not pulling a medication out on override. Maybe you gave Vanco to someone and they ended up with Redmans. Well, the only way we're going to know that is if you tell us. So you're going to notice that there's a hotline that you can call, or as mentioned, eSafe has a node where you can put it. Any of these 3 ways automatically notifies the person in pharmacy that's responsible for looking into these. So please just be aware that this is here and we do care because we do have to report these. Last slide, last soapbox. So typically at this point, I would ask anybody if they know what medication diversion is and if they wanted to tell their friends what it is. But I can't hear you, obviously, because I'm being recorded, so we'll just go with it. So medication diversion is any time someone takes a medication that is intended for a patient and uses it for themselves. I'm going to start this conversation with stuff that's simple, that nobody really thinks about, right? Tylenol. You come to work, you have a headache, your nurse director would much prefer you to take some Tylenol or some Motrin for your headache than to go home. So conveniently for you, there's Tylenol and Motrin located in your med cabinet, right? The problem with that is that yours? No. If you were to go into CVS and open a bottle of Tylenol and dump it into your pocket, what might happen? You'd be arrested, right? Because it's theft. So please keep in mind that it is not okay to take stuff, regardless of whether or not it's prescription or over the counter, just because you have access to it, okay? We do offer the ability that if you need a Tylenol or anything that's over the counter, you can call down to the pharmacy, the inpatient pharmacy, and come sign out Tylenol, Motrin, what have you, all right? There's also a CVS here on the main campus, right? If you need more than one or two or more than a day's worth, all right? So just keep in mind, don't make a habit out of this, but definitely don't take it from your cabinet. So on a more serious note, we need to talk about controlled substances. I'm going to go out on a limb and guess that everybody in the audience is aware that there's an opioid crisis going on in this nation, correct? And Tennessee is one of the heaviest areas of concern. So obviously this kind of bleeds into the healthcare profession too, right? Is anybody out there thinking that because we're professionals, we're less likely to be addicted to drugs? I hope there's nobody that thinks that. Right? Because we're stressed, we're perfectionists, we have guilt complexes over everything that happens every day. There's all kinds of reasons that healthcare providers are probably more likely to become addicted to anything than even the normal population. So does anybody know what the stat is? How many nurses are likely to have a problem with addiction? So it's 1 in 10. It's the same for pharmacists, same for providers. It's a little bit higher for CRNAs. It's about 1 in 9, all right? But that's a lot. So because of this and because this is a crisis, we're required by currently the Joint Commission, but now we're DNV, they have the same requirements, to constantly be monitoring for the potential of diversion. There are multiple ways to do this. But one of the things that has been built into the system is via technology called Pandora, which ties into the Omni cabinets. The other thing is that we actually now have a diversion specialist, that this is their full-time job to not only look at it from a nursing perspective, but from a system perspective, and to see all the holes in places that we could decrease the likelihood that somebody has access to divert controlled substances, okay? But now I'm going to spend a little bit of time telling you what Pandora is, what it does, and ways that you can be accountable for not only what you're doing, but for what your coworkers are doing, okay? So Pandora is set up so that it runs a monthly report. It is called an anomalous usage report. It looks at high users, cabinet to cabinet, right? But I'm not going to be comparing a nurse that works in the PICU to a nurse that works on CCU, all right? Because that would be apples to oranges. I'm going to look at every nurse that works on West 3 compared to every nurse that works on West 3. In evaluating those reports, if I see that, Susie has pulled 62 syringes of Dilaudid in the last 30 days, and the next highest user has only pulled 20, I'm probably going to raise my eyebrows, right? However, there's a lot of investigation that goes on. It's not just based on who's the high user. You can absolutely be a high user on this anomalous usage report and not be diverting drugs, right? Everybody knows you've probably seen that one patient, right? You can't give them enough Dilaudid, right? So if that's the case and you've worked overtime and you happen to have to take care of that patient every single shift you worked, it may not be a big deal. But if I talk to the nurse director and I find out that Susie's PRN and she's only worked 2 days out of the last 30, I'm going to be really concerned about the fact that she's touched that much Dilaudid, right? So at that point, if I also do a chart review and I find that 6 syringes of Dilaudid have not been wasted, documented as given, or returned to the cabinet, which means I have missing controlled substances, all right? And there are 6 instances where every time she went to waste Dilaudid, it took her over 6 hours. These are a lot of coincidences around this one controlled substance, right? So at this point, Susie would have an opportunity. Does anybody know what that opportunity is? It's a drug screen. right? And I call it an opportunity because if Susie's not doing anything, there's no reason she wouldn't want to take a drug screen, all right? Susie also has the right to decline said drug screen, at which point Erlanger has the right to ask her to not work here anymore, okay? So be aware that if you have a coworker that ends up going for a drug screen, there is probably reason for it, but it doesn't mean that they're diverting, right? Also know that just because somebody's drug screen's negative doesn't mean that they aren't diverting drugs. There is a lot, as I mentioned, of investigation going into the person that shows up for whatever reason it is that they are flagged on our radar. So know that there are different pieces and different reasons for everything that happens. We actually had someone, and I like to give examples just to really put it in perspective. We had an individual, we've had to terminate about 40 in the 3.5 years that I did this role before we hired the diversion specialist, that we had to terminate for suspected diversion. That's a lot of people. But statistics would say that if you're not catching 2 nurses a month at a facility this size, you're just not looking. It's not that it's good news. It just means that you're not trying hard enough to find them, okay? And that sounds morbid, but it is what it is. But anyway, back to the individual. Long story short is that we suspected they were diverting Percocet. Their charting also contributed to the fact that we thought they were diverting Percocet. Their charting was atrocious, which is a med safety issue regardless of whether or not it's a controlled substance or not, right? If you don't chart your metoprolol and the patient has a hypertensive issue, and nobody cares that you said you gave it, right? If it's not charted, it didn't happen in a court of law. So charting was atrocious. They passed their drug screen. It was negative. They were terminated anyway because of a lot of other factors. And guess what they overdosed on 4 months later? Percocet, right? So I'm going to go out on a limb and guess that we had a way to bypass the drug screen. So I just point this out to let you know that there are a lot of things that go into the investigation so that if you hear otherwise, you know that that's not the case. So how can you help? Because obviously a monthly report isn't going to catch probably a tenth of what's going on, right? Be accountable for yourself. Be accountable for your coworkers. So for instance, when you're pulling controlled substances, if it's a PRN med, ask the patient what their pain scale is, then go pull the drug that correlates to their pain scale. If they don't like Percocet, but that's what's ordered for a pain scale of 3, don't go pull Dilaudid that's ordered for a pain scale of 7. You're not following the provider's order, which means that you can get in trouble because it's operating out of scope of practice. If the patient throws up every time they take the Percocet, call the provider and ask them to change the orders. They may not want the patient to get the Dilaudid regardless, right? But they have to make that decision. Don't pull 12 Percocets at the beginning of your shift thinking, well, somebody might need one at some point, right? That's not good practice. If you pull a medication, give it. You shouldn't be carrying things around for hours. It shouldn't take you hours consistently to waste drugs. So for instance, if you know your order for Dilaudid is 0.5 milligram and all you have in your cabinet is a 2 milligram vial, get somebody, the witness that I've mentioned up here on the slide, to go with you to the cabinet to waste the other 1.5 milligrams before you ever leave the med room. You don't have to have the waste witnessed after you administer it. Do it on the front side, right? Or at least try to do it on the front side. It definitely shouldn't take you hours every time you touch Dilaudid to waste it, right? And when I'm talking about witnessing, witness it. If somebody asks you to witness the waste of morphine with them, you better be laying your eyes on some type of clear liquid being wasted, right? You already run the risk that whatever they're wasting is normal saline, but you better lay your eyes on something. Do not virtually waste. Do not trust that people are doing what they're saying that they're doing. I promise you that the most unlikely person will be the person doing this. I have yet to see any case where a nurse director, when this came up and somebody had to leave the organization because of this, said, you know, I was pretty sure they were probably on drugs, right? The person, there's not a way that addiction looks, right? Like we have to get out of our head that you can only be addicted if you look a certain way or you have certain behaviors. Most of the time, these individuals are hardworking. They're the most well-liked. All the patients love them. Their coworkers love them. Shockingly, they like to work lots of extra shifts, right? They have more access, so think about that. So notice who you're around and always, always, always witness the waste. The other thing when it comes to PCA keys, another thing that people don't really keep in mind. If you pull a PCA key, use it, and then put it back into the cabinet. Don't pull it and then share it with multiple people in your area over the course of your shift. This is the problem. Maybe one of your coworkers is diverting Dilaudid, right? And we find out that somebody's diverting Dilaudid from PCAs. And we look at who's been accessing the key. And only the CSL's been pulling it out because they're trying to help all their employees. Well, guess what? I don't know that Jimmy, who has a problem with Dilaudid, was taking advantage of the CSL and taking the key from them. I'll never know that Jimmy touched Dilaudid because he's being given the key by somebody else and probably taking it from your patient, right? So make sure that if you pull something, you use it and put it back. You don't pull Dilaudid for somebody and then give it to them. You don't know what they're doing with it. You pull it, you give it, you waste or return it. Okay? I want to be really clear about this. And again, if you see something or if you notice that something's going on that's strange, please, please, please tell somebody. I know that nobody wants to be a tattletale. I know that nobody wants to get anybody in trouble. I know that like a lot of times the problem is it's somebody that you've known for a long time and you think they're a wonderful person, right? Nobody's saying they're not. But there's still a possibility that they have a problem. And the biggest problem with the problem is that A, they could die because as I've mentioned, it's happened multiple times where people have overdosed on things they've taken from this hospital. And B, they're taking care of somebody's family member, right? Like somebody that should be able to trust at bare minimum, the person that's providing their care isn't high. So it's dangerous. So what I like to say is kind of the thought process that I instilled in our now 7-year-old. So our first child, the year he started kindergarten, he wanted to tell on everybody for everything. And so his daddy were talking about, oh my goodness, we can't let him be that kid, right, that tattles on everybody for everything. How do we make sure that he knows when it's appropriate to take it to somebody and when he just kind of needs to mind his own business? Well, in a case like this, it's very simple, and it falls into what we told him. If you know that somebody else is going to be hurt or is being hurt by something somebody else is doing, it's your duty and your responsibility to tell somebody that can handle it, right? So like I mentioned, in this case, if it's your best friend, you don't want them to die. Maybe you don't care anything about them, right? But they're taking care of somebody. They're taking care of somebody's mother, somebody's daddy, somebody's child. So turn it in for that factor. And know that lots of investigation is going to go in. Just because you report something doesn't mean they're going to be fired on the spot. There's lots of stuff that will be reviewed prior to making any type of decision like that. So if they're not doing anything, no biggie, right? It was investigated. Everybody can feel better about it. But if they are, then we can do something about it. The last thing I want to say here is that we do report to the Board of Nursing if and when somebody is terminated for suspicion of diversion or for unsafe medication handling practices. So even again, I go back to the metoprolol example. If you're not ever charting the medications you're giving, that's not safe for anybody. It's not safe for your coworkers because they don't know what you've done, and it's not safe for the patient. So regardless, it's a reportable offense. Part of the reason for this is I'm sure everybody's aware that in a lot of these cases, what happens is when these individuals either catch wind that somebody's suspicious or they are terminated from a location, guess what they do? They go down the street and they get a job somewhere else, or they go to hospice, or they go to a long-term care facility, right? That's not really helping anybody. It may be getting rid of the problem here, but it's not helping anybody. Also, when it's reported to the board, there's a lot of investigation that goes on there. And maybe what's found out is they've been reported before, right? But if people don't report it, nobody knows to look at it. And it really, really is a significant problem. And one of the, mostly are more highly sought after meds now, one that's being diverted even more so than used to be. It used to be Dilaudid and Percocets. Fentanyl has become really, really popular, right? The problem with fentanyl, you're not addicted to fentanyl long before you die. Right? So there was actually a case in a hospital in Georgia in the last 6 months where an anesthesiologist had actually placed a port on themselves so that they could infuse a fentanyl drip on themselves while they were working. Right? Insane that they could function. Well, they did function until they overdosed in the OR and died. All right? We've had people diverting fentanyl. One individual that was diverting so much fentanyl, I don't know how they could talk to us as we escorted them across the street to HR because they had consumed, by admission, 800 mics of fentanyl in a 4-hour period. All right? That's a lot, and it's crazy. But it goes back to what I'm saying about how addicts don't look or sound a certain way. If the only way you've ever seen them is high, they're going to seem normal to you. In that particular instance, had the coworkers not reported that something weird was going on, we wouldn't have known. So, last thing I'll say on this matter, if, for instance, you work in a unit and you notice that Sam is always in the rooms where there's a fentanyl drip hanging, right? You didn't ask them to go in there, but they're always lingering around fentanyl drips. Report that to somebody, right? If you notice that Jimmy always gives your patients Percocets for you to try to help you. Never helps with anything like lisinopril, but boy, all over the Percocets. That, nobody has enough time to do that, right? So be aware of what's going on. And if something seems odd, unfortunately, typically where there's smoke, there's fire, okay? So anyway, that's all I have. Thank you so much, and I hope everybody has a great day.